Hello everyone, this is Dr. Wala. Welcome to my channel. We are going to be focusing on emergencies um, and we are going to take the emergency on a problem-based learning. So we are focusing clinically upon the presentation, the management and the treatment of each emergency. We are going to start with diabetic emergencies, which we all know that they are the most common emergencies at the emergency department. But before going through the emergencies, we are going to go briefly on diabetes mellitus in a general way. So we review with each other the diagnostic criteria and the presentations. So the word diabetes mellitus originally means sweet urine. It's slightly funny because it describes the glucose found in urine, because diabetes means come through and mellitus means sweet or honey. So in medical terms, what is the definition of diabetes? Diabetes is a metabolic disorder characterized by high serum glucose, characterized by hyperglycemia. And this is due to either insufficient insulin, there is no insulin to lower down this glucose and to metabolize this glucose, or there is insulin but it's not working. Either there is a resistance or a problem in its action. So the mainstay of diabetes is hyperglycemia. Okay, so diabetes mellitus is a metabolic disorder characterized by hyperglycemia due to defective insulin secretion, action, or both. It is classified into many classes. We have type 1 diabetes, which is absolute insulin deficiency, and it usually occurs in pediatrics and have early presentation. Type 2 diabetes, it's insulin resistance or relative insulin deficiency. We have the insulin in the body, but it's not working because there is a resistance to its action, and it usually happens in older ages, and it's usually asymptomatic, and we discover these patients are diabetic either incidental findings or when they present with the complications. That's why we tend to make random blood glucose as a routine in older ages more than 40, because even if they are not symptomatic to diabetes, they may have diabetes. We have gestational diabetes mellitus, which happen in the second trimester for pregnant ladies, and we have many other specific types. What are the classic symptoms of diabetes mellitus? The classic symptoms of diabetes mellitus is due to the high blood glucose. And as I mentioned before, they are often asymptomatic in type 2. But high blood glucose makes the body feels, we have polydipsia. Polydipsia means thirst and increased water intake. And this is due to that the body doesn't have glucose. He has a lot of glucose, but it's not making use of this glucose. So to our body, we don't have glucose because he cannot utilize it. So this is enhance the feeling of drinking, and we have polyphagia. Polyphagia means hunger and eating a lot. That's a coping mechanism, I believe, because the body just want glucose since it cannot utilize it. So for it means they don't have glucose, so they are trying to make you eat more so they have more glucose. Polyuria, because there is a lot of glucose, and this is called osmotic diuresis. So a lot of glucose in urine take out water with it, and it makes you go and pee a lot. And weight loss, unintentional weight loss. It's very important to know that it's unintentional, because your body is not consuming glucose, so that your body is consuming, breaking down fat, breaking down muscles, just try to get it glucose. That's why you are losing your weight. The risk factors. Okay, what makes someone more susceptible of having diabetes or have diabetes from the start? Criteria for testing for diabetes or categories of increased risk: the pre-diabetes in asymptomatic adult. When we have someone with the classic symptoms, we straightforward go and test him for diabetes. But when he is asymptomatic, when do we screen for diabetes? Testing should be considered in adults who are overweight. The BMI is more than or equal to 25 kg per meter square and have additional risk factor. So overweight is the number one risk factor, the most important risk factors, because the fat cells produce the leptin, and which causes insensitivity to insulin, and this is the most popular theory of type 2 diabetes, and it's tend to happen in overweight. But type 1 diabetes is autoimmune disease. It's regardless of the body weight, because it's immune mediated, but type 2 is resistance. So the risk factors: adults who are overweight and have other risk factors. What are the other risk factors? Physical inactivity, first degree relative with diabetes, and it's more genetically mediated in type 2 diabetes more than type 1 diabetes. Hypertension, which is blood pressure is more than or equal 140/90 millimeter mercury, or on therapy of hypertension. And history of coronary vascular disease. And other test that he has impaired glucose tolerance, hemoglobin A1C more than or equal 5.7, or impaired fasting glucose on previous testing. So his testing are impaired for glucose, and he has a dyslipidemia. HDL cholesterol level below 35 milligram per del, or high triglyceride level. These are the risk factors. Adding to it any manifestation or any clinical condition associated with insulin resistance, like severe obesity, acanthosis nigricans. Acanthosis nigricans are like hyperpigmentation and changes in the skin, mostly obvious in the neck and in the armpit, and they are related to insulin resistance. Women with polycystic ovary syndrome, because they have insulin resistance. Women who delivered a baby weighing more than 4 kilograms or were diagnosed with gestational diabetes mellitus are also at risk of diabetes. And we know that most diabetic mothers have macrosomic babies. That's why women who deliver macrosomic baby alert us to that she might have diabetes. Okay, since we saw the diabetic had risk factor for diabetes, diagnosed them, already diagnosed as diabetic, or have high risk of suspicion, what do we do? How do you examine them? We examine the height, weight, and BMI. We examine the vitals and the blood pressure, including orthostatic measurement as well. We do fundoscopic examination, because from the complications of diabetes are retinopathy. We do thyroid palpation, because type 1 diabetes has a connection with Hashimoto thyroiditis, because it's also autoimmune mediated. And we do a skin examination for acanthosis nigricans or insulin injection sites. uh, and we do comprehensive food examination for diabetic. Why is that? Because we have vasculopathy in those people and neuropathy in diabetic, which makes them doesn't feel pain, and they are end up having diabetic DSF, and the pathophysiology of DSF is that they don't feel pain. They have injuries to their feet, and they ignore it because pain is the main alarming symptom for any problem, for any injury, and they ignore it and they get infected, and because they don't feel. So we do comprehensive foot examination, inspection, palpation of dorsalis pedis and posterior tibial pulses. Why? Because of diabetic vasculopathy. Because diabetes, in diabetes, there is a formation of fats in the blood vessel. This is enhanced the atherosclerosis and the deposition of fat in the walls of blood vessels, which make the lumen very narrow, and sometimes it occludes it in the peripheral. So that's why we palpate dorsalis pedis and posterior tibial pulses to know whether it's intact or not. And we detect the presence or absence of patellar and HLS reflexes because we have neuropathy as well, and mostly peripheral neuropathy. And we do determination of proprioception, vibration, or monofilament sensation, and all of that, as I mentioned before, due to the neuropathy. Okay, suspected to have diabetes. We done the examination for them. How we diagnose diabetes? What are the tests for diabetes and criteria for diagnosing diabetes? We have 3 tests. We have the hemoglobin A1C, we have fasting blood glucose, and we have the OGTT. Okay, hemoglobin A1C are in non-diabetes, the normal ranges are from 4 to 5.6. In pre-diabetes, from 5.7 to 6.4, and in diabetic, it's 6.5 or more. The fasting, in non-diabetes, it's usually less than 100 milligram per day. Pre-diabetes, you find it from 100 to 125 milligram per day, and in diabetic it's more than 126 milligram per day. OGTT means we give this, they are fasting basically, we give them a meal, standardized meal, 75 milligram, 75 grams of glucose, and after 2 hours we measure their glucose. And in non-diabetes it's less than 140. Pre-diabetes is 141 to 199, and in diabetes is more than 200. These are the criteria for diagnosing diabetes. Okay, what other investigations we do for diabetic? We do them routine investigations. If they came with signs of infection, we do them CBC, CRP, or ESR. We do them urine analysis if they are. If they came with complaints of UTI, according to their complaint, we do the routine investigations. We do them liver function tests. We do them renal function tests because we know that diabetes affects the kidney. And we do them fasting lipid profile because these are risk factor for diabetes. We want to know what causes high glucose, okay, and whether he developed complication or not yet. That's why we do him fasting lipid profile. We do urine albumin excretion plus spot urine to albumin to creatinine ratio, because impaired urine albumin to creatinine ratio are the first indicator to have diabetic nephropathy. and if caught in early stages, it can be reversible. We do them TSH in type 1 diabetes, as I said, because it's autoimmune and it can have thyroid problem with it. Dyslipidemias and women age over 50 years, because we know that autoimmune diseases tend to have in women more. The other tests are fundoscopy. Fundoscopy and RFT are done for type 1 diabetes from the diagnosis. We diagnose this patient today. Today we arrange them for fundoscopy and nephropathy, because it's incidental finding, as I said, and it's usually asymptomatic. So basically, when tested and when diagnosed as diabetic, maybe he has several years with this diabetes problem, and it's not properly diagnosed. So we do them from the start of diagnosis for type 2 diabetes, because we might find it already affected their kidneys and their retina. In type 1 diabetes, because it's acute and it's usually have early presentation, we do them after 1 year, and some protocol says every 5 years. But you need to check that to be more updated. What we do for diabetic patients? Mostly lifestyle modification, because they need to adjust their life to their condition, because diabetes is a chronic condition. They need to have healthy diet, low glycemic index food like apple, peach, pear, low fat milk, brown rice, and etc. Reduce fatty food intake, because we don't want to put more risk factors for coronary artery diseases and for vascular diseases. Exercise and weight reduction for type 2 patients, because they usually tend to be obese. The mainstay for the treatment for diabetes is lifestyle modification, but the medication is adjusted according to the specific case. Type 1 diabetes tend to have insulin, because they are insulin dependent. Their problem is that there is no insulin. If we replace insulin, so they can control their disease. For type 2 diabetes, other than lifestyle modification, they may need oral hypoglycemic drugs, because their problem is that they might have insulin, but they are not sensitive to insulin. So if we give them insulin, this is not going to be beneficial, because their problem is not the absence of insulin. Their problem is the insensitivity to insulin, so they tend to have oral hypoglycemic medications. Sometimes they need to be given insulin as well with the oral hypoglycemic medication. Okay. Maybe in another session we will talk about the diabetic medication. The diabetic complication, they tend to have acute, and they present in emergencies or chronic. The emergencies of diabetic patients are diabetic ketoacidosis, hypoglycemia, and hyperosmolar hypoglycemic state. The chronic complications are coming from the microvascular and macrovascular complications, and they tend to be the retinopathy, the neuropathy, and the eye problems. So this is all for this session, like an overview for diabetes, and in the next session we will be talking about the complications of diabetes.